Hi, everyone. My name is Jason Schauer, and I'm a pre-hospital physician and medical director. We are going to review the administration of blood products in the pre-hospital environment. This is related to the new Pennsylvania protocol, Optional Protocol 6095. This presentation is mandatory for all providers wishing to administer or assist in the administration of blood products. Just a brief review of Protocol 6095. It is available electronically on the Bureau of EMS website. General overview of this presentation. I'm going to lead you through a quick introduction, just discussing what blood products are available, what their purpose and indications are, some of the issues that go into administration of blood products, such as blood typing, Rh factor, adverse reactions, and then a quick review of the administration procedure. Blood and blood product transfusion is a medical procedure that involves transferring blood or its components from one person, also known as the donor, to another person, the recipient. This process is critical in treating patients in various scenarios, including things like surgical procedures, where the blood loss from the procedure is expected to require a transfusion, trauma, which is the main focus of this protocol, anemia, such as those patients who either do not create enough red blood cells or have syndromes that destroy the red blood cells. Certain types of cancer treatment, oftentimes chemotherapy, can also decrease the production of the patient's own red blood cells, and specific blood disorders, such as hemophilia or sickle cell disease, which also result in anemia. Compatibility is paramount for safety when transfusing blood products for a patient. Blood typing and cross-matching are performed to ensure compatibility between donor and recipient blood. This process helps to prevent transfusion reactions, which can range from mild allergic reactions to severe life-threatening immune responses. Blood and blood product transfusion is a vital component of modern medicine, saving countless lives each year. Ongoing advances in transfusion medicine continue to improve safety and efficacy, making this a crucial area of healthcare. Proper management and understanding of transfusion practices is essential for healthcare providers to ensure positive patient outcomes. Administration of whole blood or blood products generally is conducted in order to effect one of three main purposes. The first would be restoring blood volume. This is often the case in patients who have sustained trauma, underwent major surgery, or having gastrointestinal bleeding. These transfusions help to restore the overall blood volume in the body. In cases where patients may just be deficient in red blood cells, increasing the oxygen delivery by increasing the available red blood cells can also be very helpful to our patients. In cases where there's coagulation deficiencies, such as significant trauma with the use of whole blood, or in other bleeding disorders, certain components such as plasma or cryoprecipitate may be used in order to try to improve the amount of available clotting factors and correct the coagulation deficiency. Damage control resuscitation is a medical strategy primarily used in trauma care to manage patients who are experiencing a severe hemorrhagic shock and at risk for death due to massive blood loss. The approach focuses on rapidly restoring hemostatic stability and minimizing coagulopathy while preparing the patient for surgical intervention. Many will be familiar with many of the key components of damage control resuscitation. Early hemostasis is still a key primary objective. Skills such as application of pressure dressings, hemostatic agents, and tourniquets is still paramount in the initial resuscitation efforts. Traditionally, patients with significant hemorrhage show signs of shock such as hypotension and tachycardia have received large boluses of crystalloid IV solutions. This can have detrimental effects by diluting needed components such as red blood cells and clotting factors. Damage control resuscitation focuses on balancing replacement of circulatory volume with either whole blood or a 1:1:1 ratio of packed red cells to plasma to platelets. This shift in resuscitation strategy is seen in the development of things like mass transfusion protocols at trauma centers. Following initial circulatory resuscitation, targeted therapy for anemia or clotting deficiencies can continue with specific components to be administered. Overall, this means resuscitating the patient to a point of hopeful hemodynamic stability in preparation for surgery. Mentioned earlier in this presentation, there are several indications for the administration of whole blood and blood products. Some of these indications, such as for packed red blood cells, would be anemia. This can be multifactorial, could be related to iron deficiency, chronic blood loss, bone marrow disorders, or diseases such as sickle cell disease, which produce the incorrect form of hemoglobin. Whole blood or packed RBCs may also be used in instances where there is significant hemorrhage, such as surgery, or in the need of a massive transfusion protocol. Mass transfusion protocols are generally used in cases of trauma, but may also be used in other areas of uncontrolled bleeding, such as in the operating room with maternal hemorrhage or with significant GI bleeds. Specific blood components may also be used for coagulation problems, such as the administration of platelets in patients who have a consumptive thrombocytopenia, or in patients with coagulation disorders. These may be due to some inborn error, such as von Willebrand disease or hemophilia, or it may be related to the use of anticoagulation medications, such as a DOAC or warfarin. Administration of fresh frozen plasma or specific clotting factor concentrates often can help to correct these deficiencies. Pennsylvania EMS Protocol 6095 allows for two main indications of initiation or maintenance of transfusion. The initiation of transfusion is in patients with suspected acute hemorrhagic shock due to traumatic mechanism or otherwise known or suspected hemorrhage, as evidenced by either hypotension, altered mental status, poor skin perfusion, or tachypnea or increased work of breathing. You can see in the inset table a reference for the hypotension for pediatric patients, which is consistent with the PALS recommendations. The other indication as allowed by this EMS protocol also includes the monitoring of blood or blood product transfusions initiated at a sending hospital in a stable patient who is undergoing transfer to a higher level of care. General exclusion criteria for patients undergoing transfusion include a history of allergic reactions, history of transfusion-related acute lung injury, hemolytic reactions, certain types of infections, although they're rare, immunosuppressive conditions requiring specific treatment of the red blood cells prior to transfusion, fluid overload risk. Patients specifically in heart failure and renal failure are at significant risk during transfusion. Severe anemia from hemolysis. Sometimes adding blood products to these patients actually only feeds the hemolysis. Uncontrolled hypertension, again, fluid overload state, certain autoimmune disorders, and ultimately patient refusal. Exclusion criteria specific to this EMS protocol include patients currently in cardiac arrest, hypotension or shock unrelated to hemorrhage, patients with decision-making capacity who refuse blood products, and patients that are going to be transported as an interfacility transport who require or are anticipated to require vasoactive medications or medications that are outside of the Pennsylvania EMS scope of practice for ALS providers. Also excluded are patients who are anticipated to require an advanced airway. These patients should be taken by critical care transport. If there is any question as to whether or not these exclusion criteria apply to an interfacility transfer, the paramedic should reach out directly to their supervisor and include discussion with their service medical director. There are several different types of blood products available. These range anything from whole blood to components of whole blood, which include packed red blood cells, platelet concentrate, fresh frozen plasma, cryoprecipitate, granulocyte concentrate, albumin, and immunoglobulins. For purposes of interfacility transfers, the expectation would be either administration of whole blood or packed red blood cells. Any other blood products needing transfusion during transport should be discussed with the agency medical director prior to accepting the transfer. Several blood typing algorithms exist and are based upon various antibodies and antigens expressed on the blood cells. The two most common are the ABO system and Rh factor. The ABO system involves antigens A and B, with type O having blood cells that don't possess either A or B antigens and making it a universal donor. In many cases, when the blood type is not known in an emergency situation, type O blood is what is administered. Rh factor is another version of antigen typing, which uses the D antigen on the presence on the red blood cells. Rh positive indicates that the D antigen is present. Rh negative indicates that it is not. In many cases, Rh positive blood can be emergently given, but can be a factor in women of childbearing age. Correct blood typing is critical for assuring safe transfusions. Mismatched blood transfusions can lead to serious and potentially fatal immune reactions. In the case of ABO blood typing, various combinations of type AB, and O can be safely administered to recipients who do not have the antigens that may react with the A or B antigen, as detailed in the body of this slide. Testing for blood type for Rh factor is a separate test in which we look for the D antigen on the presence of the blood cells. In pregnancy, an Rh negative mother who is exposed to Rh positive antibodies either by carrying an Rh positive baby or through emergency transfusion of Rh positive blood can lead to a disease called hemolytic disease of the newborn, in which the mother develops antibodies that attack the Rh positive baby's blood. This is often attempted to be prevented by administration of Rh immunoglobulin, commonly called RIG, in instances of injury during pregnancy for an Rh negative mother. Moving on to blood product administration. First, you must confirm the indication for transfusion and absence of exclusion criteria as detailed previously. If uncertain whether blood is indicated, contact medical command, preferably at the receiving trauma center. If patient condition allows, obtain consent. Assure patency of IV or IO access. An IV catheter greater than 20 gauge is preferred for blood transfusion. This helps to prevent hemolysis during the transfusion. Remove the blood product unit from storage. Check and confirm blood product type and standing order for the transfusion. Document the initial vital signs and vital signs every 10 minutes for the duration of transport. A patient temperature must be obtained before transport and at the conclusion of the transport. Prepare and prime blood tubing. Blood warming equipment may also be used if it is adopted by the EMS system that you are providing care in. And begin the infusion by gravity or pressure bag depending on patient indications. Document blood product type, ABO and Rh group, unit number, and expiration date. Document the volume infused from each unit and the time of the transfusion. During the transfusion, patient must be monitored for signs of transfusion reaction, which can include fever, hives, hypotension, dyspnea, wheezing, unexplained back or abdominal pain. The provider must consider the entire clinical condition to determine if new symptoms are related to the transfusion or a change in the patient's underlying disease state. When an infusion is completed, clamp the blood product tubing and disconnect from the patient. Keep all blood product bags and tubing to hand to the receiving facility. After completion of first ordered dose of blood product, contact medical command if patient's physiologic goals have not been met for consideration of an additional blood product dose. Upon arrival at the receiving facility, notify receiving team that a transfusion was administered. provide remaining blood product bags and tubing to staff, and complete any paperwork specific to local health system and blood bank. Notify of any adverse events and communicate if an Rh positive blood product was administered to a female patient of childbearing age or younger, often defined as less than 50 years. This table delineates the reaction level and the steps to be taken by the provider in the case of a reaction during transfusion. Mild reactions where there is no worsening of vital signs and potentially only a rash or itching, you may continue the infusion and contact medical command for guidance. In the case of a moderate or severe reaction, the transfusion should be paused but not disconnected from the patient, and medical command should be contacted immediately. General guidelines for the transfusion of blood products includes an initial rate of about 2 milliliters per minute for the first 15 minutes to monitor for any immediate reactions. The subsequent rate can be increased as the patient tolerates to approximately 150 to 300 milliliters per hour, depending on the clinical situation and the patient's tolerance. Platelet concentrates typically infuse from over 30 to 60 minutes. FFP, 30 minutes to an hour. Cryoprecipitate usually infuses over about 30 minutes to an hour, and whole blood follows the same practice as packed red blood cells. There are some additional notes and caveats to the protocol. You should not delay transport for establishment of blood product administration. You should follow statewide protocols for initial patient contact and the approach to the crashing patient. If the patient is injured, you need to follow trauma triage protocol and the multi-system trauma or traumatic shock protocol. If the patient is alert with decision-making capacity and the condition allows, you should attempt to obtain informed consent for the blood product administration, otherwise implied consent applies. In volume resuscitation efforts in patients with hemorrhagic shock, the preferred resuscitation fluid is blood products. Crystalloid boluses, such as normal saline or lactated ringers up to 1 liter, can be initiated if blood products are not available. This is consistent with advanced trauma life support recommendations as well. Blood products to be considered include whole blood, and if whole blood is not available, red blood cells and plasma and balance ratios are also a good option, but are dependent upon region and availability. The shock index should be assessed. This is determined by dividing the heart rate by the systolic blood pressure and will be detailed on the next slide. The shock index is a simple clinical parameter used to assess the hemodynamic status of a patient. It's calculated by dividing the heart rate by the systolic blood pressure. A normal shock index ranges from 0.5 to 0.7. Values above this range may indicate potential hemodynamic instability, such as in the case of shock or significant blood loss. Specific to Jersey Shore area EMS, patients receiving blood products and needing transfer to a higher level of care who have a significantly elevated shock index should be considered for critical care transport. There are a few specific complications that the provider needs to be aware of when monitoring a patient receiving a transfusion. The first would be TACO, or transfusion-associated circulatory overload. This is a significant risk with blood transfusions in patients who are elderly, infants, and those with underlying cardiac and renal disease. TACO occurs when the circulatory system becomes overwhelmed due to the volume of transfused blood products, leading to acute pulmonary edema and a heart failure-like symptoms. This is very similar to seen when patients receive too much IV fluid with similar underlying conditions. Knowing some of these causes and risk factors can help to prevent the syndrome of TACO. The volume overload can be in part minimized by decreasing transfusion rate, and occasionally the administration of Lasix, but this should be done through medical command. There are patient-specific risks, such as advanced age, compromised cardiac and renal function, and low body weight, which all can contribute to the development of TACO. The blood product type is also somewhat specific. Products that contain blood plasma, like whole blood or FFP, are also at higher risk for causing volume overload. Complications produce symptoms such as dyspnea, hypoxia, tachycardia. Blood pressure can be increased, as well as the presence of JVD. Sometimes you can hear crackles on lung auscultation, which would be consistent with the development of pulmonary edema. They may also start to develop some peripheral edema, or in some cases you'll also notice a little bit of abdominal distension. As I mentioned earlier, prevention strategies really are recognizing patients that are at high risk, slowing infusion, potentially the use of diuretics. Again, this should be done in conjunction with discussion with medical command, and just really carefully monitoring these patients during their transfusion. If you suspect that the patient is going into fluid overload, either stop or reduce the transfusion rate. Don't disconnect. Consider the need for possible diuretics and other supportive measures as far as providing additional oxygen or non-invasive ventilatory support for respiratory distress, much as you would do for anybody else who is having a fluid overload state. TRALI, or transfusion-related acute lung injury, is rare, but a pretty serious life-threatening complication of transfusions. This is actually related to a specific injury of the lung and not so much the actual fluid overload state. Causes of TRALI are believed to either be immune-mediated, meaning that they're due to antibodies and antigen reactions, or non-immune mechanisms in which the preservatives and other elements of the transfusion product actually causes activation of neutrophils. TRALI usually presents within about 6 hours of the initiation of a transfusion. Most often it's in 1 to 2 hours. It is a little bit difficult to sometimes differentiate this from TACO, but oftentimes they have mostly respiratory complaints without some of the other signs of fluid overload, such as peripheral edema. They may also exhibit fever, hypotension, and cyanosis. Aggressive respiratory support is often needed for these patients. Risk factors in this case are high plasma blood products such as FFP. Occasionally you can also see it with whole blood. There are some donor factors which are interesting but probably not pertinent to the EMS provider, such as multiparous women and also patients who donate who have had multiple transfusions themselves. Some patients with underlying inflammatory conditions may also be predisposed to TRALI. One particular case that comes to mind is often sepsis patients who receive transfusions can be at an increased risk as well. Prevention strategies are more on the side of the blood bank, including demographics of donors, leukoreduction, and at the provider level, avoiding high-risk patients. Management in these cases includes the cessation of transfusion as detailed in the protocol under moderate and severe reactions, supportive care for oxygen supplementation. Fluid management is important, so if you have any concomitant IV fluids running, you may want to avoid these unless if there's severe hypotension. Diuretics are not usually helpful in this case because the problem is actually an injury to the lung causing edema and not fluid overload. Overall, this completes the training for the Protocol 6095. If anyone has any questions, please don't hesitate to reach out to me. Happy to discuss any questions and try to get any answers that you may need. Thank you for listening.